My name's Ed Tanner. I'm the chief of the G1 Oncology Division here at Northwestern. And I'm joined by Dr. Daniela Matei, who is a G1 medical oncologist in our division and a force as a researcher and clinician for taking care of women with gynecologic cancers, especially ovarian cancer. Just going to take a look just to make sure that we have everybody in the room. I think the number was 37, so I think we should be good to go. I'm really excited about this event tonight. This is a kind of a mini symposium, so I know there's so many things that we could talk about this evening, and I'm sure there will be lots more questions and things that then we'll be able to cover in our breakout session, but hope you'll find it interesting and useful. What we decided to talk about are things that Dr. Matei and I encounter every day, certainly just as everyone else over the last 6 months as we try to navigate taking care of patients who have ovarian cancer during the pandemic. And so we're going to kind of weave in some of the changes and things that people have asked us about what's safe and how care has changed during this time, and then also touch on some of the new therapies that are coming out and perhaps how those might be impacted by COVID as well. Obviously, that's a lot to get through in 30 minutes, but we'll try our best here. And if you do have questions, put them in the chat and we can address them at the end. So no disclosures. We're going to discuss how COVID-19 has impacted the care of women with ovarian cancer, and weave in a few updates in therapies that have come along in the last year, and then perhaps how COVID-19 impacts the treatment of chemotherapy treatments of patients with ovarian cancer. So I think not just in cancer care, but obviously the rest of our lives are really, profoundly affected by COVID. But when we think about how the coronavirus has impacted ovarian cancer care, really think about diagnosis, surgery, systemic therapies, and surveillance for patients. And at the time of diagnosis, we've all been, since the very beginning, very concerned about how COVID-19 would impact the new diagnosis of ovarian cancer and perhaps leading to treatment delays. And we've been kind of seeing some degree of this in many aspects of our care. Diagnosis delays is perhaps one of the ones that's hardest to quantify, but might have the biggest effect. So we have closed offices, so patients who have symptoms were not able to get in, especially in the beginning. A lack of testing, a lack of facilities for surgery or even treatment. And then there are other things that are a little bit softer, perhaps women that are afraid to go to see their doctor or to ask if something is abnormal. And then finally, what impact having a COVID-19 illness would have on starting treatment for someone with a new diagnosis. So we don't have a lot of data about this, but there is an emerging amount of data, and I'm sure we'll find a lot more about this in the coming months to years. But if you look at the rate of new cancer diagnoses, and I don't have this for ovarian cancer, but if you look here, these blocks are for the five more common types of cancer. You see breast cancer here on the left. The dark green bar is pre-COVID, and you see in the weeks of March and early April, the decrease in the number of new diagnoses of cancer. And different cancers have seen different decreases in the rate of diagnoses, but overall we did certainly see in the early weeks of the pandemic a decrease in the delay, about 46%. It was different by cancer type, but across the board a decrease. We won't know for a long time whether it has any impact on survival, and the hope is that these delays didn't extend much past that point, but still it's a significant concern. And I think this is especially problematic for ovarian cancer because we know, while everyone here knows that despite the fact that in the media we hear that ovarian cancer is a silent killer, it really isn't. That there are some symptoms that are noticed, but oftentimes they can be more subtle in some patients, and that without interaction with a healthcare provider, that these things could be missed. And so the things that we all, I think as advocates, making sure that women know about symptoms of bloating and pressure and fullness and change in bowel habits are things that should prompt an evaluation by a provider are really important. Telemedicine may have some role in this, but exactly how in the long run that'll be utilized is not totally clear. What about surgery? So in the very early phases of COVID, we saw a decrease in OR capacity. ORs were converted to ICUs. We had a lack of testing, so there was a lot of concern about whether patients might have an early infection and then would have surgery and then get very sick from COVID, and we didn't really know as much, especially early on. And then also what would happen patients who were recovering, would this lead to a more severe COVID illness? So, and there's certain procedures that we know have higher risk. So anything that causes aerosolized particles like intubation and laparoscopy, so we're filling the belly with gas, can lead to spreading of COVID. So it was really important that we had accurate testing. I'd just like to share, I wish I could find the original slides for this, but this was data from a meeting that we had in March, and this is an internal demonstration of how ORs were closed as we tried to reach peak capacity here at Northwestern. You can see the number of additional ICU bed space as we closed each of our ORs to allow 227 additional ICU beds during that period from mid-March to late April. And you can see this starting to drop off, which is exactly what happened. But this was a tremendous effort to try to make sure that we had capacity, which fortunately we didn't exceed that, but came very close to it. But now we're back to baseline. We made a lot of changes to improve safety. Right now, there's really limited data to suggest that surgery for patients with GYN cancer, really surgery in general, that there's an increased risk associated with COVID infection, especially now that we have routine testing available. So I now feel very comfortable for patients, as best as one can be, that with negative testing prior to surgery, that we're able to offer safe surgery for patients or any procedure that they need to have done. So everyone now undergoes COVID testing 48 to 72 hours before surgery. Of course, there's wide, universal masking. And to protect patients, we have N95s, eyewear, and appropriate PPE to make sure that staff are limiting exposures so that they don't infect patients later. So, we do think that probably that major surgery, that patients may have increased risk if they were to get COVID, be asymptomatic when they have surgery, but with widespread testing and more accurate testing, hopefully we can really limit the chance of that happening. So now I'm going to move on to systemic treatments. I think this is really the bulk of what we wanted to talk about today. So, I think that we all have concerns about the impact of COVID infection on patients receiving chemotherapy. This is something that we, very immediately tried to address, but we didn't have a lot of data about this. The only data that came out about this was in May, about a very small series of patients from China, from the same province of Wuhan, 205 patients from mid-January to early March who were admitted with a COVID-19 infection. So just to note this, these are patients that tested positive. So this isn't like all cancer patients. These are people that were sick enough they got tested. So we know these are going to be people who are more sick, especially early on where testing was less widely available. So there was a high rate of mortality in this context. And patients who had received chemotherapy recently, especially high-dose chemotherapy, different than what we usually give for ovarian cancer. So hematologic malignancies, where they're really trying to knock down the blood cell function, seem to have be associated with higher risks of serious COVID infections. Unfortunately, there weren't a lot of, we didn't have a lot of data to share about this for patients with GYN cancers. In this study, there were, I believe, 9 patients with cervical cancer and maybe a couple patients with ovarian cancer. It didn't even say the numbers, but none of those patients died. But I do think that these results probably overstate the risks of serious infection and death from COVID, because these were highly selected patients who were admitted to the hospital during the very peak of the pandemic, where patients now would probably be tested and a lot more patients would test negative. So, because of the risk of serious illness, we've been very careful for the last 6 months. But we also recognize that there may be different risks depending on the type of treatment the patients are receiving. And we do have some good news to share. Just despite the pandemic, there's been a lot of new research that's come out in the last year and even in the last 6 months that's been very promising for women with ovarian cancer. And so I'd like to kind of discuss a little bit about that. And I'm going to go through some standard chemotherapy information just about COVID. And then Dr. Matei is going to jump on here in a minute and talk more about some of the novel treatments. So as far as standard, so the different broad classes of treatments that we might be concerned about. So standard chemotherapy drugs like carboplatin, paclitaxel or Taxol, Doxil, these kinds of drugs are the biggest class. Then we have VEGF inhibitors like bevacizumab or Avastin, immunotherapy drugs like pembrolizumab or Keytruda, and then the different PARP inhibitors. So we'll briefly touch on each of these groups. For standard chemotherapy drugs, we know that most of these drugs decrease the white blood cell number and their function, and that generally increases the risk of infection. And because COVID-19 not only, in theory, chemotherapy could increase the chance of getting COVID, but it may make the kind of secondary infections that we see with COVID, like pneumonia, worse. These drugs can also decrease platelets, and we know that COVID-19 is associated with risk of blood clots, and actually decreased platelets can both cause bleeding and clotting. So this is another concern. But now we actually do COVID testing of all patients before they start chemotherapy. Now that doesn't completely prevent them from getting COVID while on treatment, but we really stress the importance of being careful and self-isolating for patients who are on chemotherapy. So we do have a little bit of data about this specifically for women with gynecologic cancers. And this was just released, I believe, in the end of July. This was a group of institutions in New York, NYU, Sloan Kettering, a few other hospitals in New York, of women who tested positive for COVID-19. So there's 121 women, 46 with ovarian cancer. Unlike that Chinese study, these were not necessarily women who were hospitalized, just women who tested positive. So about 14% of women with GYN cancers were hospitalized, which is actually not dramatically higher than the average population. 10 did develop severe COVID-19, meaning in the ICU at least. But interestingly, surgery and regular standard chemotherapy did not increase the risk of hospitalization or death from COVID-19, which is encouraging. Now, there's probably a lot of things that we don't totally understand about actual risk, because these are just patients who tested positive. So we don't really know the total denominator number of women who had COVID in that area who had GYN cancers. But still, I think this was overall encouraging that perhaps being on chemotherapy doesn't greatly increase the risk of getting COVID-19 or being admitted to the hospital. So now we don't know whether it increases the risk, whether cancer itself increases that risk at all. But that's kind of a separate issue that would be a lot harder to answer. Also, just briefly mention the VEGF inhibitors like Avastin or bevacizumab. These drugs block blood vessel growth. They don't have a major impact on immune function, and bevacizumab has been used for the treatment of ovarian cancer for quite a while. It does have some increased risk of bleeding and clotting. There's some interesting data coming out now about using VEGF inhibitors like bevacizumab to treat patients with severe COVID-19, which kind of makes sense. So high VEGF levels are associated with pulmonary edema, so fluid in the lungs, and respiratory problems. So there's actually a study going on right now in China looking at giving bevacizumab to reduce the levels of VEGF in the bloodstream in patients with severe COVID-19 infections to see if that actually might improve outcomes for people with severe COVID-19, which is pretty interesting, I think. So it doesn't seem like treatment with the vaccines by itself dangerous. So I'm going to turn things over now to Dr. Matei, who's going to talk a little bit more about some therapy updates on PARP inhibitors and immunotherapy, and perhaps how that might impact COVID risk as well. So turn things over to Dr. Matei.
Thank you so much, Ed, and hello, everyone. It's a pleasure to be with you tonight. Ed gave a fantastic review of the impact of COVID on our daily lives. I have to confess that last year at this exact time, this past weekend, I participated in a very unusual conference, which was called Conference of the Future, how we would imagine future. So I was invited and I spoke about what I thought medicine will look in the future, you know, kind of making predictions about advancement in treatment and genomic medicine and so forth. Little did I know that this pandemic was going to hit and how different our lives will be, not in the distant future, but in the real near future. So having said that, I think over the past few years, we've seen some remarkable changes in the treatment of ovarian cancer. And I think the most outstanding progress that has been made was the discovery and the approval of PARP inhibitors. So what is PARP? PARP is an enzyme that naturally repairs the DNA. And this DNA break can occur in any normal or cancer cell as a consequence of just cell division, just the normal aging of the cell, or as a consequence of treatment with radiation or chemotherapy. PARP inhibitors are a new class of small molecules that inhibit this enzyme. So if you can imagine that the enzyme is blocked, then the DNA is not repaired, and as a consequence, the cancer cells cannot divide and grow, and then they undergo cancer cell death. Very interestingly, this was a discovery that was made 10 years ago, was that cells in which other enzymes that are also involved in the repair of DNA, such as the BRCA proteins, if those are intact, PARP inhibitors are not that effective. However, when you have a double hit, the BRCA is mutated, and this can happen in about 10 to 15% of patients with ovarian cancer and with breast cancer, then hitting the cancer cells with a PARP inhibitor leads to a complete disaggregation of the chromosomes. These are the chromosomes inside the cell, so there's kind of like a genomic chaos, and the cell cannot repair the DNA and undergoes cell death. So from these basic science discoveries that were happening about 10 years ago, about over the past 5 years, we've seen the testing of PARP inhibitors in various contexts in the clinic. This was one of the first studies that looked at olaparib treatment given as a maintenance after platinum therapy for relapsed ovarian cancer in patients with BRCA mutated ovarian cancer. And you can see here, we as oncologists look at these curves that indicate how many patients survive when they receive a certain treatment. The upper red curve corresponds to patients that received olaparib, and the blue curve corresponds to patients that received placebo. The further apart these curves are, the greater the benefit. Typically in oncology trials, we see the curves being just a little bit apart. This wide separation is very rarely seen and was really unparalleled in prior research in ovarian cancer, this representing a significant advance. In particular, for patients with the BRCA mutated, the separation of the curves was even further apart. Aside from olaparib, two other PARP inhibitors, niraparib and rucaparib, have been developed in parallel, and similar sort of survival curves and improvement in progression-free survival, meaning the duration of remission, was observed with both niraparib, as shown here, again in patients with mutations, and also with rucaparib, which I don't have the time to show today. But what was very remarkable was that the benefit of PARP inhibitors initially observed only in patients with BRCA mutations was also noted in patients without a BRCA mutation, as observed particularly with niraparib. Furthermore, as these drugs continue to be developed in more recent trials, they were brought in the upfront treatment, meaning after surgery, chemotherapy, patients, initially patients with a BRCA mutation received olaparib versus a placebo in this landmark trial, the SOLO-1 trial. So these are patients first diagnosed with ovarian cancer carrying a mutation. And as you can see here, the survival of these patients without recurrence is absolutely remarkable. More than 50% of patients that received olaparib had no evidence of recurrence at almost 5 years after treatment, which almost makes us wonder whether this type of treatment, particularly for those patients with a BRCA mutation, can in fact induce a cure, even in patients with advanced ovarian cancer. This trial was followed by 3 other trials that were reported last year. I'm showing here just one in the interest of time. The PRIMA trial looked at niraparib maintenance, again in patients with a BRCA mutation or another alteration in the same pathway that governs repair of the DNA. The curves are widely separated. Next slide. And interestingly, this is observed, the separation of the curves is also observed in patients without mutations in the DNA repair pathway, which this trial basically brings us a new treatment that we can use in all patients with ovarian cancer, of course, individualizing by their characteristics. Lastly, PARP inhibitors, the role of PARP inhibitors in the treatment of ovarian cancer is also solidified by this small trial that took a long time to complete, where patients with recurrent ovarian cancer associated with the BRCA mutations were treated with either a PARP inhibitor or with chemotherapy. Who would have thought that a few years ago that a targeted agent specifically directed to DNA repair would in fact induce better outcomes? The PARP inhibitors is shown in green compared to standard chemotherapy. So again, now we have another option to treat our patients, particularly those that do have BRCA mutations or other alterations in this DNA repair pathway. taking home messages, we have a new class of very active drugs. I think this is a step forward, almost as the discovery of carboplatin and of Taxol, the standard treatments for ovarian cancer. We currently have 3 drugs with similar level of activity. There are some differences in the indication profile, but it's likely that all of these drugs are highly active. They have some differences also in the type of toxicity. They are mostly active in those patients with tumors associated with a mutation. We're still working to figure out of those patients that don't have a mutation, who are those that are likely to respond. A lot of research in the field is also going on in the area of resistance to PARP inhibitors and what type of combinations might be able to overcome this resistance. Perhaps in the COVID area, the use of PARP inhibitors would be considered one of the safest options, as typically they don't cause a lot of immune suppression. They don't require too many visits to the doctor. And I don't know if there are recent data, but I would anticipate that the use of this a form of targeted treatment might have increased in recent months. Many questions remain. Which PARP to use, when to use the PARP, can we combine them with other drugs? Are there long-term side effects? This is an important question, particularly as we bring these drugs in the use immediately after chemotherapy. And one of the concerns about the use of PARP inhibitors remains potential for development of leukemia. Next slide, please. In regards to immunotherapy, this is a new type of treatment that basically activates the host immune system. Typically, lymphocytes are able to recognize foreign objects such as cancer cells. Next slide, please. And under normal circumstances, they would be able to eliminate the cancer cells. However, when the cancer has set in for a prolonged period of time, the lymphocytes become blinded and they don't see the cancer cells. The newer therapies for immunotherapy, the newer immunotherapies attack a mechanism of exhaustion of immune cells, allowing them to become again active and recognize the cancer cells. Next slide. We have a number of new drugs that inhibit this mechanism and are able to reactivate the immune cells. Next slide. However, although these drugs have induced remarkable responses in lung cancer, melanoma, kidney cancer, in ovarian cancer, responses have remained modest in the single digits, which brings the question as to whether combinations of immune therapy are required. Next slide, please. And I think a lot of research is going on in the area, trying to combine anti-PD therapy with other immunostimulatory drugs, or with chemotherapy or other biological treatments. We are all looking forward to development in this area. What it is known about COVID-19 and immunotherapy. Initially, I kind of advise my patients that perhaps immunotherapy is the safest treatment to take because it would boost your immune system to fight cancer and fight infection. However, there are concerns from recent trials that immunotherapy, in fact, by activating the lymphocytes, could trigger this inflammatory state